So this is actually the last histology topic, special senses. So time goes by fast, right? So in this lecture, it's actually supposed to cover the eye and the ear. But if I do both, it's going to run over the time limit. So I'm only going to do the histology of the eye. And then you will just read on your own the histology of the ear, okay? So that will be for today's topic. Then also we will have lab under my batch of special senses. Then next week on April 30th, that will be lab for Dr. Warfay's batch. Okay. I still have not gotten the scores of Dr. Warfay for his practical exam. I kept reminding him, but as soon as he gives me his scores, I will encode them. But until he doesn't give it to me, I cannot give you your grades for that. Okay? That's why your scores haven't been posted. I don't know why. I kept reminding him many times already. But he hasn't given it. Then on May 7th, you will have the last topic of the year, which is a special topic under Dr. Warfay. His topic is for 2 meetings. Okay? It is diseases of the immune system. Okay? Diseases of the immune system. 2 meetings. Also use that time after his lecture. One batch will have their review and the other batch on review. That will be your review because on May 21 will be your histology final exam. Okay? May 21. Remind you. May 21. This final exam will be done by me. Okay? I am in charge of the final exam. The coverage is all topics ever since the beginning of the year. Okay, it is your final exam. Again, the format is PowerPoint and moving exam. Okay. No multiple choice. Okay. You know my style already. Okay. So that's going to be our schedule for the rest of the year. Okay. We're almost there. Made a lot of progress. All right. So, any questions regarding the schedule? Okay. So, you will have time after Dr. Warfay's lecture to review that. You can review all slides on that day. Okay? So make sure you take that opportunity. Alright, so today we are doing special senses. We're going to focus on the histology of the eye. Now, actually, I think this is one of the best ways to end the year, the histology of the eye, because the histology of the eye requires you to master all the 4 basic types of tissue. Epithelial, your connective, your muscle, your nervous. Because the eye has them all. Okay? And the eye is a very complicated organ. It's a very complicated organ. But the histology is a work of art. It's very beautiful. Okay? So, we'll begin. Are you familiar with what condition this cat has? Yes, that's correct. It's common in cats, particularly in white cats. White cats are prone to have these genetic defects. So this is 2 colors of the eye. It can also happen in humans, and it can also happen within the same eye. So you can have one eye that's partly blue, the other one that's other part brown. So it doesn't have to be the entire eye. It can be separate. So very common in white cats. So let's begin. So it is a highly developed photosensitive organ for analyzing intensity and color of light reflected from objects. So what we see is actually light that's being reflected from an object, and then our brain interprets that as sight. Okay, so everything that we see is merely just a reflection of light and its colors. Okay? This is going to be the anatomy of the eye. So we cut the eye. We're cutting the person to the side. The eye rests in a socket or a little space, which we call the orbit. Okay? And it's surrounded by bones on the anterior, on the lateral and posterior and superior and inferior surfaces. The anterior portion is open. Okay? So take a look at this one. Okay? And it's also divided into chambers. We have the posterior and the anterior chamber. Okay? But we will focus more on the histology. Okay? So the eye is divided into layers, or what some authors call as tunics. Okay, tunics, means layers. Now, there are 3 layers, or 3 tunics. The outermost layer is mostly collagen. Okay, that's collagen. And so your outer layer is going to consist of two structures. The majority is called the sclera. Okay? That's the white portion of the eye that you see. The white portion, that's the sclera. Okay? At the very anterior portion of the sclera, you have a very specialized type of tissue, which we call the cornea. Okay? The cornea is a little different from the sclera because, firstly, the cornea is avascular. Okay? There's no blood vessels. Because if there's blood vessels, you'll be seeing blood in your visual screen. Okay? And the collagen fibers are more parallel. It's dense, regular collagenous connective tissue in the stroma. The sclera is a little bit irregular, dense, irregular collagenous connective tissue. Okay? So this is the outer tunic that's predominantly collagen, the collagenous layer. Okay? Underneath that layer is called the vascular layer. It's called vascular layer, although because it has a lot of blood vessels, but there's more than just blood vessels. Predominantly, there's a lot of blood vessels. So this is called the uvea. Okay? The uvea consists of three structures. The majority is this red one that you see here, is the choroid. That's the choroid. Okay? As we continue anteriorly, the choroid will become the ciliary body. The ciliary body is predominantly smooth muscle. Okay? And it has these processes which you call the ciliary processes. Okay? And then it actually will attach via these zonae ligaments to the lens. Okay? So it actually will attach to the lens, and it can adjust and modify the shape of the lens for accommodation, okay, for reading close up. Okay? Then if you go even more anteriorly, you have this structure here, which is called the iris. Okay? The iris. The iris is the part of the eye that gives you color, the color of your eyes. Okay? Within the iris, there's an opening. That opening is the pupil. So when you see the cat's eye or someone's eye dilate, it's the pupil that's enlarging. Okay? Because this iris actually has muscles which can control the diameter of the pupil, allowing more light or limiting light to go in and out of the eye, or more in rather than out. So this iris is has a lot of muscles, and I'll show you the histology of that later. And then lastly, the innermost layer is the neural layer, which is more commonly referred to as the retina, or the retinal layer. Okay? The retina usually is only limited to the posterior and middle portion of the eye. It doesn't extend up into the ciliary body. Instead, it's replaced by epithelium, okay? Which we'll show you later. Okay? So those are the three tunics. Okay? Collagenous, vascular, and your neural. Okay? Let's look at each of them. Before that, we'll briefly look at the embryology of the eye. So the eye actually develops as an outgrowth of the brain, the prosencephalon. And it will begin as an invagination. This invagination will take a portion of the ectoderm and eventually form the lens vesicle, which will become the lens, and then the mature eye. So it's basically this. This is from your Huntera, so you don't actually have to take pictures. It's in Huntera. It's there. Alright, so we'll go one by one through the different layers. I gave you the overview. We'll look at the sclera. Okay? So the sclera is important because this is where your extraocular muscles will attach to. Okay? So there are several rectus muscles and oblique muscles in the eye which control the movement of the eye, and they all attach to the sclera. Okay? And this is the majority of the collagenous layer. Okay? And it's predominantly type 1 collagen. Okay? This is important because there is a disease that affects the sclera when there is a defect in type 1 collagen synthesis. Do you know what defect that is? There's a defect and it gives the very characteristic blue sclerae of the eye. Are you familiar with that? Where else do you see type 1 collagen? Bones. So this one actually manifests as bone weakness, increased bone fractures, as well as blue sclera. That's osteogenesis imperfecta. Osteogenesis, because they're both type 1 collagen. And that's a defect of type 1 collagen fibers. And I do have another separate PowerPoint on abnormalities of the eye. That's for pathology. Alright, so here's what it looks like histologically. This is a nice picture, and we actually have a very nice one in our lab today. The eye is very nice in our lab. So it's cut, we're looking at the overhead view. Here's the sclera. This is the sclera, and this is the cornea that it becomes continuous with. This here is the eyelid. There's an eyelid here, portion of the eyelid. The conjunctiva is here. We have the bulbar conjunctiva. Okay. Then here's the iris. Okay. Here's the pupil, the opening. This is the lens. Here's the ciliary body. And then it would continue on there. So this is the overhead view of the histology of the eye. Okay. So the sclera, the only thing you need to know, it's continuous with the cornea, dense, irregular collagen and tissue. Sometimes you might find blood vessels. Sometimes. But let's now compare that to the most anterior portion, the cornea. Okay. The cornea is a very beautiful in histology, and it's very special. Okay. What do you think gives the eye most of its refractory power? Do you think the lens? It's actually the cornea and the tears. The tears that cover the cornea and the cornea itself. They're the ones that give your eye its refractory power. It's not the lens. You think it's the lens because it's that big thing that focuses everything, but it's actually the cornea. Okay? So the cornea is very important for visual acuity. Okay? So let's take a look at this diagram. So here we have a little inlet of the cornea. If you look at the cornea, it's got a unique histology because it's one of the few places where the basement membrane is actually visible. Okay? Usually you don't see the basement membrane underneath the epithelium because it's very thin. But in the cornea, it's a little bit thicker because there's fluid in the anterior chamber and it helps prevent fluid from escaping and entering. So let's take a look at the histology of the cornea. This is the anterior portion, the very surface of your eye. Okay? So the anterior surface is lined by non-keratinized stratified squamous. Okay? Non-keratinized stratified squamous. Underneath this is the basement membrane. But this basement membrane has a special name. It is called the Bowman's layer or the Bowman's membrane. Okay? Bowman's membrane. You've heard the word Bowman before. You've heard it in the Bowman's capsule. And if you also remember it rests by Bowman's glands in the olfactory. They're all the same doctor, Dr. Bowman. He discovered 3 things. One of which is in the kidney, one is in the nose, and the other one is in the eye. All 3 are Bowman's. Bowman's glands, Bowman's capsules, Bowman's membrane, or Bowman's layer. Okay? Then underneath that, we have the main bulk of the cornea, which is the stroma. Okay? The stroma is your type 1 collagen fibers. Okay? Now they are arranged parallel and at 90 degrees angles. Okay? The way that they are arranged makes it actually transparent. Okay? Unlike the sclera, which is dense irregular collagenous connective tissue, the dense regular collagenous connective tissue here are almost perfectly aligned, allowing light to pass through. So it's transparent. Take note that it's also avascular, no blood vessels. That's why when we can easily do corneal transplants. Okay? Corneal transplants are easier to do because we don't have to worry about tissue rejection. Okay? Unlike other tissues, like if you want to do a kidney transplant or liver transplant, they all have blood vessels. Blood vessels carry a lot of antigens, so we need to match the blood type, we need to match the tissue type. But since there's no blood vessels, you don't have to worry so much about that. Okay? Less of a hassle. Okay? Now let's go to the posterior portion. Now, some authors call this as the epithelium, and others call this posterior portion as the endothelium, because it's on the inner surface. Okay? So this endothelium is lined by simple squamous epithelium, single layer squamous epithelium. And it also has a very prominent basement membrane, which we call the Descemet's membrane. The T is silent. Descemet. Descemet's membrane. Descemet. Sounds like no T in the pronunciation. Descemet. Okay? So that's the diagram of the cornea. Let's look at some actual slides. Oh, okay. The text first. Okay. So it's transparent, avascular, stratified squamous on the anterior, Bowman's membrane underneath. Then for the stroma, the fibroblasts are actually special. Okay, they're called keratocytes. Okay? So the ones that you saw making the collagen fibers are not your typical fibroblasts. They produce They're different cells, keratinocytes. Okay? Then the posterior is simple squamous with the descemetase membrane. Alright? And here's what it looks like histologically. Alright? So let's review the parts. Which one is the anterior, which one's the posterior, right or left? Which one's anterior? Right, okay. So what's the lining epithelium, although it's blurry on here? That's correct. Then, oh, it's really blurry. No, it's not blurry on my screen. Underneath that, there's a pink basement membrane, which is known as the Ohm's layer or membrane. We can call it layer or membrane. Then we have the stroma. Now, when you look at the stroma, you'll notice that there are spaces. Those spaces are not actually there in the real life, but these are artifacts when we process the tissue. So ignore these little white spaces because in actuality, they're perfectly compacted and parallel. It's just an artifact of processing the tissues. These are your keratinocytes. They look like fibroblasts. Okay? They look like fibroblasts, but they're kind of similar to that. Then this is the endothelium, simple squamous, and what's the membrane underneath that? Yes. Good job. All right. So the eye, that's only one portion of the eye. Here's what it looks like. You really can't see the basement membrane. It's very prominent. One of the few places you can see it. Okay. All right. So that's the review. And here's another in high power. You can see the thick pink right here, and also the pink here. Those are the two membranes. Next, we have the junction of the cornea and the sclera. Okay, some people call it the limbus. Okay. So this here is the sclera, and then if you would continue on upward, it would be the conjunctiva. Okay. At the junction, you might see small little vascular channels. Those vascular channels serve as the draining site for your aqueous humor. Okay? So that's the fluid portion of the anterior eye. There's fluid, aqueous humor. So the aqueous humor, if you remember, is produced by what structure? Ciliary process. Okay? So your ciliary processes, and you read it in advance. Your ciliary processes are going to produce your aqueous humor. Your aqueous humor will then enter into this chamber, and it's actually going to go from the posterior chamber, and it's going to go behind the iris, and then it's going to enter through the pupil to enter the anterior chamber. And then when it's in the anterior chamber, it's going to drain off into this little meshwork, which we call the trabecular meshwork. And then from the trabecular meshwork, it will enter the canal of Schlemm. There's a lot of special names in here. Canal of Schlemm. And then the canal of Schlemm is usually found at this junction between the cornea and the sclera. Okay? And then from the canal of Schlemm, it will drain into your venous system. Okay? That's actually how your aqueous humor will drain. Now, there are some conditions where there is failure of the drainage of the aqueous humor. What is that medical condition where the aqueous humor cannot drain properly? That's correct. So you guys are very good. Glaucoma, that's correct. Now, there are two types of glaucoma. We can have an open-angle glaucoma, or we can have a closure-angle glaucoma. In open-angle glaucoma, there is access to the anterior chamber. There is access. It's open. That's why it's called open. There's access to the anterior chamber. But the problem is in the trabecular meshwork. There's something blocking the trabecular meshwork from entering the canal of Schlemm. Okay? It's like a clogged drain. Okay? It's a clogged drain. So if the drain is clogged, nothing's going to exit. That's open angle. In closure angle glaucoma, what happens is usually the iris is unusually adherent to the lens. Therefore, the aqueous humor has no access to the anterior chamber. So it can't even go to the anterior chamber if it wanted to. That's called angle closure glaucoma. Okay? So the signs and symptoms of glaucoma: eye pain, bright halos when you look at light. Sometimes you get redness, and then the eye gets really firm, and there's building up pressure. And this pressure damages the optic nerve. Optic nerve is very sensitive, which can eventually lead to blindness. Okay? It's not treated. It is one It is something that you need to take care of. Okay? That's what's called. Alright, so that was the collagenous layer, or the outer layer, cornea and sclera. Let's move on to the next layer, the vascular layer, which is the uvea. Okay? Now the uvea consists of, already I mentioned, three structures: choroid, ciliary body, iris. It's also known as the middle vascular layer. Alright, so the choroid will be here, mostly in the posterior and middle portions, right in between the sclera and the retina. It's kind of sandwiched in between. Then it continues on as this smooth muscle, as the ciliary body, and then lastly the iris. So let's take a look at them one at a time, starting off with the choroid. Okay? Now the choroid is actually divided into three layers and structures. Okay? So the outermost layer, which is closest to the sclera, is called the suprachoroidal lamina. The word super because it's on top. It's the outermost layer. So this is the one closest to the sclera. So it's easy to identify. Suprachoroidal lamina. Now when you look at it histologically, it has a lot of melanin pigment. Okay? Now the inner surface of the eye, or the inner portion of the eye, has abundant melanin found in the choroid. And the purpose of this melanin is it prevents light from being reflected within the retina. Okay? In human eyes. In cat's eyes, they're a little different. They actually want to reflect because they have their nocturnal, or nocturnal, so they have good vision in their eyes. But humans, we don't have that reflectory power. So that's why we have a lot of melanin pigments. Okay? That's your suprachoroidal layer. Then we have underneath that, because it's more inward, inside, it's underneath that. So we have the inner choroidocapillary, because there's blood vessels this side. Choroidocapillary lamina. Okay? This has less melanin. Okay? So the difference, the supra has melanin, the inner is capillaries. Okay? So two layers. And then lastly, there's another membrane called the Bruch membrane. Okay? Bruch membrane is going to be the one that separates the choroid from the retina. Okay? It's another basement membrane that separates structures. This one, in this case, separates the choroid from the retina. Okay? Not quite as prominent as the bone intestine, but if you look carefully, it's actually there. Alright? So take a look at that. Let's take a look. Alright? Let me orient you first. Here, this portion is the sclera. So we see a little portion of the sclera. So what's the outer layer of the choroid? Suprachoroid. And what's unique about that histology? These are the melanin. See them well here? It looks black on here because there's a lot. It's actually brown, but there's so much that it looks black. So this is that layer. Then underneath that is the you see these blood vessel spaces. It has less melanin. This is the inner. So this is the supra. This is the inner choroidocapillary layer. And then this portion here is the entire retina. This is the layer. The retina has several layers. See how many layers? And yes, you will have to memorize each layer. It's actually not so hard. I know it looks intimidating. It's not so hard. And then it's a little hard to see, but there's a little pink membrane separating the retina from the choroid. That's your Bruch membrane. Okay? So let's show what it looks like. Here's another one. So this one again in low power. And sclera is here. Densely regular collagenous connective tissue. Then you have the one that has belly, supra. Then you have your inner. And then you can see the line now. See the pink line? That's your Bruch. And then everything up here is retina. And another picture again, this one is focusing more on high power. You can see the capillaries. Okay? That's why it's called the choroidal capillary layer. Lots of capillary, less melanin. Okay? And this is a preview of what you will learn later in a moment. The layers. Don't worry, I have several pictures of the retina. Let's move move on. So anterior to the choroid, it is continued as the ciliary body. And the anterior most of that would be the iris. So we're in the middle portion, ciliary body here. So the importance of the ciliary body is that it contains three things. Okay? The most important is the muscle, which is called ciliary muscle. It's a type of smooth muscle. Okay? So it's actually a type of smooth muscles. Okay? And when they contract, they're actually attached to the lens. Okay? They're attached to the lens by these little fibers, which are called the ciliary zonulae. Okay? Ciliary zonulae. They're kind of like cords that are tethering the ciliary processes of the ciliary body to the lens. And when they contract or relax, they'll either pull and adjust the shape of the lens. Okay? And then when it's relaxed, the lens will recoil back into place. Okay? The other one are these little finger-like extensions of the ciliary body, which are called the ciliary processes. Okay? The ciliary processes would actually be where your aqueous humor is produced. They're coming from those little finger-like processes. And they also have melanin pigment as well. Okay? They also have melanin because it's actually continuous with the choroid. It's part of the choroid. Or if it's part of the uvea, it's part of the uvea. It should have melanin to help prevent the reflection of light or the scattering of light. Okay? And this layer is also going to be covered by an epithelium. Okay? The epithelium is usually columnar, okay? Variable sometimes, it's columnar. Because there's no retina in this portion. The retina is only at the middle and posterior. But once you get to the ciliary body, there's no retina. The retina stops here. So, let's take a look at that. Here's that picture again. This is the ciliary body, composed of the ciliary muscle. Okay? You'll notice that there's also pigment within the muscle too. There's also pigment. There's really a lot of pigment in the choroid. Then you have these finger-like or these little papillary-like projections. These are your processes. Okay? And then look, very faintly, you can see these little, they look like little threads. That's your ciliary zonulae. And they attach to the lens. Here's the epithelium that will be replacing the retina. It's usually columnar, tubuloidal. The melanin is at the basal portion. Basal portion. So these are a little high-power view of the ciliary processes. The ciliary muscles are still up here in the upper right-hand corner. And here's the flow of the aqueous humor that I mentioned a while ago. Okay? So from your ciliary body, goes behind your iris, through the pupil, enters the trabecular meshwork, then through the canal of Schlecht, and then finally through your venous system. Next, let's go to the anterior most portion of the uvea, which is the iris. Okay, iris. That's the one that gives you color to your eye, depending on the amount of melanin that you have. Alright, so it is the most anterior portion of the uvea. It's going to cover part of the lens and has a central opening which can actually change in size. Okay, that opening is the pupil. Okay, so when you see the pupils dilate, that means the opening is getting wider. The opening is getting wider. Okay? So if we look at the iris, the anterior portion of the iris does not actually have epithelium. There's no epithelium on the anterior portion. Instead, it's just connective tissue, fibroblast, and several melanocytes. Okay? That's kind of unusual because most things are always covered by an epithelium, right? Always an epithelium. But this is one of the unusual things that it doesn't have an epithelium. And then the stroma is also going to be areolar connective tissue and melanocytes and blood vessels. The posterior actually does have an epithelium. Okay? The posterior has an epithelium and it has heavy amounts of melanin. So the anterior, no epithelium, less melanin. Posterior, epithelium with heavy melanin. Okay? And there's going to be two types of muscles. Okay? So we have first the dilator pupillae muscle, which from its name dilates the pupil. And then the other one, which is near the center of the pupil, is actually called the sphincter pupil muscle, which actually constricts the pupil. So there are two muscles, and I'll show that to you. So here is a picture of the iris. So we can see a little portion of the lens. The little lens is here. The pupil is here. This is a little, see that opening? That's the pupil. This is the anterior portion. There's no lining epithelium. It's actually just fibroblasts. Okay? And very scanty amounts of melanin. But look at the posterior. It's heavily pigmented. Okay? But the more pigmented it is, the darker your eye color is. Okay? What is the eye color of someone that is albino? That's pure albino. It's reddish pink, right? What do you think is the cause of that reddish pink if they have no melanin? What you're actually seeing are the red within the blood vessels. So the redness in someone that's albino, because they have the failure of producing melanin pigment, what gives them the color would be the small blood vessels within the iris themselves. Okay? So this is iris. Now let me show you some pictures. Here are the blood vessels. So in someone that's albino, you'll see those red blood vessels. That's why they have the red eyes. You watch too much anime, those villains that have the red eyes. They don't have enough melanin pigment in their iris. Now for the muscles. Oh, I forgot to show you the muscles here. The one that's closest to the, this is actually only a portion of the iris because it won't fit in the entire slide. It's actually longer, a little bit longer. You have to see it several. But the muscle here, this thick muscle that's closest to the end, that's closest to the pupil, it's the sphincter. This is the one that constricts the eyes. Sphincter pupillae muscle. The other one that's thinner and more laterally located is the dilator. So the sphincter closer to the pupil, dilator more to the sides. It's usually thinner. Okay? Dilator pupil is here. The sphincter is here. Okay? Does this have albinism? You see albino? What's the color of his eyes? Is that what you see in albino? Just because something is all right doesn't mean that he's albino. This is a different condition, leucism. So this actually does produce very little melanin. Okay? I actually saw this in real life. This is a very famous crocodile that they had at my zoo back when I was living in the States. Very popular. It's actually not that big. It's still a juvenile. Most of the time, these things don't survive because they get sunburned and they're easy prey when they're small. You can easily see them getting eaten by predators. So this guy, he still has melanin pigment, hence the blue color. Not all that are white are albino. Another condition. Because the albino has the red eyes. So we've finished the middle layer. Let's talk about something special, the lens. Okay? Now, the lens plays a secondary role in visual vision. Okay? Its main purpose is for changing shape for accommodation when you look at things close up. Okay? Its shape is maintained based on the tensity of the tension of the ciliary zonulae and the ciliary body, depending on its constriction or relaxed state. Okay? They will adjust the lens. Okay? So it's a biconvex structure suspended behind the irises, which focuses light on the retina. It is also a vascular, because if there was blood vessels, again, everything will be blurry in your vision, because it's right in front of your retina. And it actually has a lot of elastic tissues, because when the ciliary body is not pulling on it, it actually recoils back into shape. It's very elastic. So here are the components. On the outer surface, it has a capsule, which is called the lens capsule. Okay, easy enough. This lens capsule is where your ciliary zonule will attach to. So we attach to the capsule. Interestingly enough, underneath that is the epithelium. Okay? So underneath the capsule is the epithelium, which is called the subcapsular lens epithelium. But this epithelium is present only in the anterior surface of the lens. It is not seen in the posterior surface. Okay? I'll show that to you later. And then for the main stroma, it's composed of lens fibers. Okay, lens fibers. Okay? They're a special type of fiber that have a lot of crystallines. Okay? And these crystallines form a transparent tissue which helps reflect the light for refraction. Alright, so let's take a look at that drawing before we look at the histology. So here's the drawing. The outer surface, we have this thick collagen lens capsule. Then underneath that we have the lens epithelium, which is usually cuboidal to columnar. There it is, cuboidal to columnar. Okay. And then the main stroma is the lens fibers. Okay. And then take a look, notice the donula attaching to the capsule of the lens. So here's the histology. This is the low power, ciliary body, iris, cornea, anterior chamber, pupil. Here's the lens. This side would be covered only by the epithelium. There's no epithelium on the posterior surface. Then let's show it to you in higher power. This is the transition. Here is the anterior, here's the posterior. Notice there's no epithelium here. There's no epithelium on the posterior surface. But what we see is this thick capsule. That's a capsule. And it's really out of focus. Well, this is ideally the epithelium. Maybe we can get it a little bit more focus. Is there someone who's very tall? Who's very tall in our class? I can't reach. Anyone can adjust the focus? No one's tall enough? Never mind, you just have to look at blurry images for the rest of your histology. It's even blurry. This is your imagination. Alright, here's another picture. See the lens fibers, how they're very nicely parallel, avascular, similar to that of your cornea, but this one has crystallines for more refractive power. Okay? Here's the lens capsule, here's the epithelium. And then here's the zonule. So this is the response for near. So during the near response, the muscle will actually contract and the shape of the lens become more oval. Right? When you're this is for looking at close objects. When you're looking at far objects, the ciliary muscles relax. But what happens in someone that has presbyopia? What is presbyopia? Very common. So have you ever noticed that like, the older people, when they read, how do they read? Like that? They have to go like this. They hold it up away from each other. You see that, right? You see that? That's a different problem. So in presbyopia, what happens is the lens loses its elasticity. Okay? So when it loses its elasticity, they have difficulty reading things that are close up. Take note, this is different from myopia, nearsightedness. Like me, I can't see things that I can only see things that are close up. I have difficulty seeing far away. Myopia and hyperopia. Hyperopia, you can't see things that are close up. Myopia, you can't see things that are far away. Okay? Nearsightedness and short-sightedness. It's different from presbyopia. Presbyopia, the lens cannot accommodate. So they have difficulty seeing things close up. In people who are like me, who can't see far away, what actually happens is the point of reflection is going to be in front of the eye. The other one is away from the eye. So they have to move closer or further away to get it to focus. If you're interested in diseases in the eye, I have a PowerPoint for that. Alright, so those were the eye. Next, the last layer, the retina. The most challenging probably for histo. Several layers, a lot to know. Okay. So the retina is the innermost layer of the eye. It is the neuronal layer, the nerve layer. It covers the posterior 2/3 of the eye, but it falls short right at the ciliary body. Okay. And let's take a look at it. So it is the innermost unit of the eye. It's divided into two basic layers, but those basic layers are further subdivided into several more layers. Okay? So in terms of function, it's outer and inner layer. Okay? The outer layer is the one closest to the Bruch membrane. Remember the Bruch membrane, the one of the choroid that separates the choroid from the retina? This is also heavily pigmented as well. And this is called the outer pigmented layer. The outer pigmented layer. This does not have a nervous portion. It's not part of nervous. It's just heavily pigmented. But the inner layers will have a lot of nerve tissue. The inner retinal region is the true neural layer. Okay? It's thick and it consists of several layers of neurons and photoreceptors. Okay? So let's talk about the retinal pigmented layer. So this is cuboidal to columnar cells with abundant melanin pigment. The purpose of this is to absorb light so it doesn't scatter. Same as your choroid. Okay? But it also acts as a barrier because it's next to the Bruch membrane. The barrier prevents things from entering the retina, things that you don't want. Okay? It also is going to provide support, removal of free radicals, and in case of damage, it can give rise to other tissues, except for most neurons. All right, so let's take a look at it and look at it. I have a pointer. So at the top, all right, so up here, see the sclera? So that's the sclera. Then you have your supra that has a lot of melanin pigment. Then you see the capillary, that's the inner choroidal capillary layer. The Bruch membrane is a little thin. It's here. Bruch membrane is a little pink. And then you see the inner pigmented layer here. That's your pigmented layer of the retina. Okay? That's your outermost layer. It goes from outer to inward. Sclera, choroid, retina. So that's the outermost layer. Then the inner is everything else. This is all inner. This is all inner. Okay? So, that was the easiest layer. The retinal pigmented layer. Retina pigmented layer. That's the easiest. It's the outermost layer with pigment. Let's go to the more complicated layer. The neural retina. Okay? This consists of 9 distinct layers. Okay? But we're going to break it down so it's easier to digest. Okay? Rather than just go all at once. Okay? We're going to break it down. 3 of those layers will contain nuclei of neurons. Okay? And when you see a bunch of neurons that are together, collections, those are nuclei. Okay? So let's look at the first one of the 3 layers of neurons. It's called the outer nuclear layer. Okay? Now the outer nuclear layer contains the nuclei of the photoreceptors, which are your rods and cones. Okay? The actual cells that receive stimuli for light are your rods and cones. Okay? And they are found, here are the 3 nuclear layers. 1, 2, 3. So there are 3 nuclear layers. Okay? So that's already 3 layers. The one that's on the outside, closest to the sclera and the choroid, is of course called the outer nuclear layer. That's this one here. Here's your choroid, here's your pigmented layer. I'll talk about this layer later, but we're focused on this one. This is your outer nuclear layer. These are the nuclei of your rods and cones. So that's easy, right? So far, outer nuclear layer. Let's look at the other two. If there's an outer nuclear layer, there must be an inner nuclear layer. Okay? So the inner nuclear layer consists of neurons that are bipolar, okay? As well as horizontal cells and other cells that integrate signals from the rods and cones. So the inner nuclear layer is here, because this is the outside, this is the inner. You may think that this is the inner, but this actually has a different name. So don't mistake this for middle. There's no middle. It's outer, inner, and then this one has a special name. I know it looks like it would be the inner, and you think this is the middle, but this is actually composed of a special cell, so it has a special name. So these cells, they actually receive signals from here, and then they carry it to this next layer. That's the purpose of this layer. It helps relay the layers. So what's the very last of the nuclear layer? Well, because they're made of a special cell, these cells are called ganglion cells. So we call this your ganglionic layer. Remember your ganglion cell from your Auerbach plexus? Yes. Pseudo-unipolar? Yeah, that's why it has a special name, because these are ganglion cells. So they contain ganglion cells. And the axons coming from this ganglion cell will enter and make up the nerve fiber layer, and the nerve fiber layer will become the optic nerve. So it's actually these cells that are responsible for producing the optic nerve. Okay? So this is actually the three nuclear layers together with the nerve fiber layer. I'll show it to you. So here are the three layers. Three nuclear layers plus the nerve fiber layer. Outer nuclear layer, inner nuclear layer, ganglion layer. Now sometimes this ganglion layer is going to be thin, especially when you go to the periphery. Okay? When it's closest to the posterior, it's really thick like this, but it can become thinner. Okay? So just take note of that. Sometimes it's only a few cell layers thick, especially towards the edge of the retina. Okay? But here, this is the middle, so this is the ganglion. So these are ganglion cells, and then their axon will go up here. And so this layer is going to be forming the optic nerve. So this is going to be eventually the nerve fiber layer, because this is the layer composed of axons coming from the ganglion cells, which makes the nerve, the optic nerve. Okay? So the names of these layers actually do make sense. Okay? They make sense. It's just a lot to take in. Right? But there's more, because we still have these other layers in between. But at least this is 4 of the 9. Just 5 more. Okay, so far so good. Is this understandable so far? The 3 nerve layers and then plus the nerve fiber layer? Okay, let's make it more complicated. Okay, now between those nuclear layers, we have fibrous layers, or what we call as plexiform. Okay? Plexiform regions, which is actually your neurophil. It's more neurophil, if you remember from your nervous system. So here we have an outer plexiform layer. Okay? So here's the outer plexiform layer. It's here. And this actually consists of axons that are originating from your rods and cones. So your rods and cones are making axons that are all intermingled in here, forming this outer plexiform layer. And then their axons will enter into this inner nuclear layer to synapse with the neurons here. Okay? So outer plexiform layer. We haven't talked about this yet, but we'll go to this later. This is this special. So outer plexiform layer. It's just axons coming from your rods and cones sending signals to this. That's it. Next, if there's an outer, there must be a inner. Okay? So we have the inner plexiform layer, and they contain axon and dendrites, which will connect the inner nuclear to the ganglion layer. So it's the same function. It's here, it's the inner plexiform layer. And what's this composed of? Axons coming from here. and then communicating to the ganglion. So it's all going up. If you notice, the signal is all going to come upward, ending in the nerve fiber layer to become the optic nerve. They're all going up. That's the goal, to go up. So this is the inner plexiform layer. So we have 1, 2, 3, 4, 5, 6. Next, we have the actual layers of the rods and cones. This is not to be confused with the nuclear layer, the outer, because that one contains only the nuclei. But when we talk about the rod and cone layer, this is actually the part where the photoreceptors are. This is where the light is stimulated. So the layers of rods and cones, it's named after the cell shape. I'll show you a picture of it later on. And they're very specialized neurons. And they're found here. So your actual photoreceptors are actually here. They're way down here. The actual things that respond to light are here. Rods and cones. So that means, where do you think light is coming from? From top to bottom or bottom to top in this one? Are you sure? This is the choroid. This is the choroid. How does light go through the choroid and through the sclera? I'll show it to you. Let's look at this one. You see, here's the retina. Here's the light. Light goes here. And so, what is this layer? It's actually here. Then your photoreceptors are way down here. So it actually has to penetrate through all the other layers before it can reach its rods and cone layer. Okay. So if I go back to this picture, light is coming from here, and it has to penetrate all of these layers before it reaches the rods and cone. So it's actually, because remember the orientation? This is the innermost layer, right? This is the innermost layer of the three tunics. The very innermost here will be up here, so light goes up and down. It can't go through here, or else it has to go through your orbit. You can't do that. Light doesn't go through your bone and skin so easily, right? So that's how it goes. I'll show you another picture. So here we go. Layers of rods and cones. Okay. So next layer. Next, we have the outer limiting layer. Okay? It's actually here. It looks like a basement membrane. It separates the outer nuclear layer from the layer of rods and cones. This very thin pink line. It looks like a basic membrane. See it? Outer limiting layer. Yeah. It's not actually a membrane, but it looks like a membrane. This line. Outer limiting membrane. So how many have we looked at? 1, 2, 3, 4, 5, 6, 7, 8. One more layer. If there's an outer limiting membrane, there must also be an inner limiting membrane. So the inner limiting membrane is actually going to separate the retina from the vitreous, which is actually at the very top. This one, at the very top of the surface of the retina, in cyan, which separates it from the vitreous, is the inner limiting membrane. Okay? So now we have looked at all of the layers. So for light to enter and reach the layers of rods and cones, it must go through the inner limiting membrane, nerve fiber layer, ganglion layer, inner plexiform, inner nuclear, outer plexiform, outer nuclear, outer limiting membrane, and then finally reach your rods and cones. And then once these are stimulated, where does the signal go? The signal goes backwards. So the signal will transfer and finally enter the ganglion cell, and then the ganglion cell will produce axons in the nerve fiber, and then it goes out via the axon. So the light goes down here, but the signal goes up. They're going different directions. Okay? Confusing. Is it confusing? But you have to think of It's actually not that bad. Are you confused? Because remember, think of this, the eyeball diagram. Okay? We go back to the eyeball diagram. See? Retina, choroid, sclera. Light can't go backwards from here. Light can't go from here. It's impossible. Light has to go from here. So it goes this way. Down. And go backwards. Okay? Alright. Now let's look at your. So light must pass through all layers of the retina before reaching the rods-and cones receptor. Okay? So here's the flow of light, which I made with yellow arrows. So it must go through all the layers in this order. Alright. Now let's look at the photoreceptors. So rods and cones. Okay. So rod cells, there are about 92 million rod cells on average. These are very sensitive to light. This is actually what allows you to see in dim lights, like at a movie theater where the lights are down low. Okay? And they're called rod cells because the shape of the photoreceptors are kind of like a cone. They're very, well, not really cone, they're cylindrical. Cylindrical shape, elongated. Your cone cells, on the other hand, they're the real cone cells. These are less numerous, okay? And they produce one of three classes of colors. Okay? All the colors we see are actually a combination of the primary colors. Okay? So we have three types which respond to red, green, and blue. The way it's mixed will actually give you the various lights. But what we see is actually very limited. You may think we see a lot of colors, but if you look at other specimens, particularly the mantis shrimp, the mantis shrimp actually has 16 different types of photoreceptors. They can see more color than us humans with our only 3 types of colors. That's why they have very sharp vision. Okay, those mantis shrimp, the one that punches. They have very, very keen vision, among the best in the animal kingdom. Okay? So if you ever have someone that's colorblind, it's usually due to a defect in one of these cone receptors. If they're completely colorblind, all 3 types are malfunctioning. But usually what you get is someone who can't see blue or green. Okay? But it depends. There are actually different types of color blindness. Very, very different. So anyways, they contain the visual pigments. Okay? These are the visual pigments that respond to the color, giving us our color. Alright? Here's what it looks like. So up here, you see the nuclei of the cells? This would be the outer nuclear layer. And then this is the layer of rods and cones. The actual photoreceptor part is down here. Okay? This is the actual photoreceptor. See the rod shape and the cone shape? So, layer of rods and cones, outer nuclear layer up here. That's why. Right? And this is what it looks like. Here is the choroid, supra. Then the inner is kind of thin, the bruche. Then there's the pigmented layer of the retina. Then this is the layer of rods and cones here. So then your photoreceptors will be here. It's actually hard to really see the actual cone shape. I know it doesn't look like a cone or a rod, but they're all intermingled, so it doesn't look so clearly like that. But this is where it would be. Here's a nice view of your outer limiting membrane, which separates your outer nuclear layer from your layer of rods and cones. Okay. So this is another high power. Then at the very top, outer plexiform layer. So, I'll show you this one because this picture is taken more in the periphery. Sometimes your ganglion cell layer can be very thin, okay, especially in the sides. So what I showed you earlier was towards the center where it's very thick and prominent. But towards the end, sometimes the ganglion layer is only just a few cell layers thick. So that's your aggregate cell layer. Okay? And then I have one more thing to show you. Any questions so far? I have one more thing, just the accessory organs. The tears. Questions so far? Almost done. Look at some of the accessory organs. All right. First, we have the conjunctiva. Do you remember what's the lining epithelium? Of course, it's right there. So that's why columnar was on. Good job. So it's actually a thin, transparent mucosa that covers the anterior portion of your sclera, as well as the inner surface of your eyelids. They cover your inner surface of your eyelids. And it actually produces these goblet cells. They also produce a portion of your tears. Okay? Your tears are not just from your lacrimal glands, but they also come from the goblet cells of your, although the bulk does come from your lacrimal glands, but they're also part of your goblet cells. Right? So here's the parts of the conjunctiva. Okay? You have the palpable conjunctiva. That's the inner portion of your eyelid. So have you learned to do the eyelid inversion test in your have yet? Have you learned that in your physical examination? You get the Q-tip and you flip the eyelid. Have you done that yet? Yeah. So what you're actually looking at is the palpable conjunctiva. That's where you take the Q-tip and you pull the eye roll around. You do that, right? That's the palpable conjunctiva. Then here at the where it makes a U-turn, this is the formical conjunctiva, and the part that's on the sclera is the bulbar conjunctiva. So here's the lining epithelium, stratified lumbar, with goblet cells. Then we have various conditions, pink eye, conjunctivitis, usually due to viral infections. It's contagious, so do not touch it. Usually viral. Next, we'll talk about the eyelid. So the eyelid is a specialized structure that's there to protect the eye, but it also has a lot of secretions. There are glands. There are some important glands that we need to know. So, lining the inner portion is the palpable conjunctiva. Within the eyelid, you're going to see muscles. Okay? This muscle is the orbicularis oculi muscles. It's the eyes that you use to open and close your eyelids. Then here, on the inner portion, you're going to see your tarsal plate. I'll show you your tarsal plate. And then you have your eyelashes and associated glands. Let's take a look at them in detail. So here is a section of the eyelid. These are the muscles, your orbicularis oculi muscles. Your tarsal glands are actually sebaceous glands. Okay? They're actually sebaceous glands. So similar to your sebaceous glands that you see elsewhere in the skin. Okay? Yes, it is. They also secrete an oily substance into the conjunctiva as well. So your tears are not just water, it's also a mix of your goblet cells, your tarsal glands as well. Very common condition, these can sometimes become inflamed. I'll show you a picture of that. The sty and the organ. Yes. Next. So here it is. The tarsal glands, they're also called Meibomian glands. So depending on your textbook, it's tarsal glands or Meibomian glands. They're the same. Tarsal, Meibomian glands. Next, we have another thing. we have glands of Z's and glands of mole. Okay? Your glands of mole are modified apocrine sweat glands. Okay? The normal apocrine sweat glands, where do you find that? Normal apocrine sweat glands? That's apocrine secretion. That's apocrine secretion. But the actual apocrine glands are in the axillary and the genital areas. Okay? Although, yeah, apocrine secretion is a mammary gland. So, but these are specialized apocrine glands. Okay? They're not exactly the same. They're a little bit different. Okay? And these are apocrine glands that are found near the base of the eyelash. Okay? Base of the eyelash. And then you have another type of sebation gland called the glands of Z's. Glands of Z's. These glands of Z's, glands of moles, they can also become infected. They can cause swelling of the eyelid. Okay? It's known as the stye. I'll show you later. Okay? Glands of Z's, glands of moles. So the difference, glands of Z's, sebaceous glands. Glands of mole, modified apocrine glands. Both of which empty at the hair follicle, the eyelashes. Okay, it's just one is sebaceous, the other is sebaceous. Right? Next, you have your lacrimal glands. This one is actually responsible for producing the bulk of your tears. Okay? And so, what's the function of tears? They moisten and lubricate and supply O2 to the corneal epithelium. Okay? The corneal epithelium is alive. It needs oxygen and nutrients as well. And they also have some antimicrobial properties due to isozyme. Here it is. So if we actually look at the layers of your tears, it's actually like this. Okay? You have three layers. The oil layer, the water layer, and the mucus layer. The oil are made from your arsal glands. Okay? Water is made mostly from your lacrimal gland, and then your mucus are the goblet cells. So all of which contribute to the tears that are covering your eyelids. So, here's what it looks like. They're just mucus glands. Mucus and sometimes serous glands. Next one is seromucus. I will show you one last one. And it's not going to be included in the exam discussion that I'm showing you right now. But some of these pictures are from my actual residency training. When I was a resident, I was known to be toxic. I always get the weird specimens. Whenever we get big or complicated specimens, it just happened to be on YouTube. And it's very rare that we actually get high specimens. But lo and behold, I got 5 in 1 year. 4 or 5 in 1 year. Which is a lot, because we hardly ever get only 1 or 0 oftentimes in a year. But I got 5. So I think that's why I was also asked to teach when it comes to optometry. So I'm going to show you some of the more common eye disorders. Are you familiar? Are you familiar with proptosis? That's the protrusion of the eye. Okay, that's proptosis. It can be both eyes or it can be one eye. Do you know what condition do you think this one is? Graves. Graves. Very characteristic of Graves' disease. So Graves' disease is an autoimmune disease where it targets your thyrocytes, and they produce excessive thyroid hormones. Okay? Causes proptosis. Okay? This is from Robbins. So for neoplasms, the most common neoplasm in the orbit are going to be actually depending on the age. They're usually vascular in origin. Infants, it's papillary hemangioma. Young children, lymphangioma. Adults, cavernous hemangioma. That's that red birthmark. the birthmark that appears red? That's capillary hemangioma. Very common in children. They have this red birthmark. It usually fades away if it's small, within 2 to 3 years. Sometimes if it's big, it doesn't fade away. But it's not just common or red, it's common throughout the body. So capillary hemangioma. You don't need to know that one. Here's the lymphangioma, don't need to know that one. Cavernous hemangioma. The difference between capillary and cavernous, capillaries are small capillaries. Cavernous, look at the size of the blood vessels. They're huge. You're dying. You're dilating. That's the difference. You learn about this. That's why you need to be strong in histo. If you don't know the normal, how are you supposed to identify that this is abnormal? So, I will show you. Remember again, we have the glands of mole, glands disease, and your Meibomian glands. They can become, here's the histology, they can become swelled and infected. Okay. So there are actually 2 conditions. So the first one is called lesion. The lesion is inflammation and blockage of the Meibomian glands. This is the Meibomian glands. Remember, the Meibomian glands are in the inner surface of the eye. So the swelling tends to be under the eyelid, rather than if it was in the glands disease where it's like a tip near the eyelash. So these are more inward places, and they present as a firm, slow-growing, painless nodule. Slow, firm, growing, painless nodule due to infection or blockage of this. So it's in the inner portion. They look like this. Here it is. You notice the mass is more direct inside. It's not at the tip, it's not at the eyelash, it's more inside. Oh yeah, correct. But there's another one that's a little different. They can be confused because they're both in the eyelid. The other one is the stye. The stye is actually more bacterial. And this actually presents as painful nodule. It's a painful nodule, and it's more at the lid margin. Because the other one is innocent, it's in the Meibomian gland. This one is actually in the gland disease or the glands and moles. So they're located more here. Yeah, whereas the lesion one is here. It's French. And sometimes you'll see that it's got this pus. It's painful. Okay. Very painful. Then for malignant tumors, the most common malignant tumor is basal cell carcinoma. It's actually the most common tumor worldwide. It's a skin cancer. It's a type of skin cancer. Not found only in the eyelid, but throughout the skin. So risk factor, UV radiation, fair skin. So if you go out without sunblock and you have fair skin, you're susceptible to that. So it presents as a light tan papule, and it usually has prominent blood vessels. Sometimes it can ulcerate, and when it ulcerates, that's called a rodent ulcer, because it looks like it was eaten by a rat. So we call it rodent ulcer. This pathology has some weird descriptive terms. Rodent ulcer. Really? There's also eel in rigor mortis, which is part of your digestive. But anyways, next, let's skip this one. Oh, this one I have to show you because it's so common. Pterygium. You definitely will encounter this one because it's so common. So pterygium is a triangular thickening of the bulbar conjunctiva. It looks like this. See that little pale thing? You see this commonly in elderly people. Okay? It doesn't cause problems until it encroaches the cornea above the pupil. That's when it will actually cause visual problems. But it's usually painless and it's just irrelevant. Pterygium. So this little fleshy triangular shape thing. Okay? Pterygium. The problem is once it starts growing here in this area, then that portion of the field will be blurry. Because remember, the normal cornea, it's avascular. But here it's blood vessels and sclera. Collagen is regulated. If you need to know the histology, it's here. You don't need to know. It's not going to come out of your template. This is actually the cornea. Here's the anterior. Here's the posterior. Okay. And then you see this slope, not normal portion. You don't need to know that. The other one that's also common is called a equecula. So this one, it's actually a raised lesion. It's a bump. It forms a yellow bump on the eye. Again, also seen in elderly. See this one? This one here? Common in elderly. The problem is because it's shaped different, it makes irritation in the eye. The eyelids, the tears, they go in the ears and everything. It causes irritation. There's another one there. There's what it looks like. Don't even know it. Some other neoplasms, we have benign nevi, moles. You can have moles in your conjunctiva as well. Well, they're benign. Some people actually have them. If you look at their diastole. But here's from my case. This is a case of squamous cell carcinoma. It was benign. It was benign. You actually can't see the eyeball because in front of the eyeball there was a mass coming from the inner eyelid, this fleshy mass. This fleshy mass grew in front of the eye, so that when I cut it, you can see the fleshy mass. Here's the eyelid, here's the fleshy mass, the eyeball is back here. Squamous cell carcinoma. Okay, one of them. Here's the very characteristic blue sclera of osteogenesis imperfecta. It doesn't look blue, it looks gray, but trust me, it's blue, it's just the projection is looking kind of weird. The projector is kind of weird. It's really blue, bluish gray. This guy gray, cornea, okay, up here. Here's your myopia, nearsightedness, and hyperopia, farsighted. So in these conditions, there's a refractory error. It's either a refractory error or the size of the eyeball is a little out of shape. So that the nearsightedness, it focuses in front of the retina. So they have to go closer to see it properly. Whereas in farsightedness, it focuses beyond the retina. So they have to step back to see it. This one's the more common one. Not to be confused with presbyopia, which is different. Ooh, this one's unusual. Keratoconus. Anyways, I won't explain it, but the sclera, the cornea, the stroma of the cornea becomes thin, and the Bowman's membrane breaks. So instead of having a round eyeball, it collapses, it forms like a triangle. So if you notice the eyeball, it's pointy. It's pointy. Let's look at another view. Look at the shape. Keratoconus. Not common here in the Philippines, more in European nations. Don't even know that. Cataracts, I'm sure you've seen cataracts. Some of them can be congenital. There are many different causes for cataracts. Okay? This one was due to congenital rubella syndrome. Okay? This one is senile cataract, this is where you see it in elderly, also in people that are diabetic, people that have uncontrolled diabetes, very, very prone to developing cataracts. Glaucoma, this is the one I mentioned, the two classes. So this one is open angle. It's not draining into the trabecular meshwork. Okay. Then the closed angle is here. This is the closed angle. It has no access to the anterior chamber. Okay. Then for the iris, probably the more common one. The most common primary intraocular malignancy is uveal melanoma, okay, which is different from typical melanoma because it's not related to UV exposure. Normal melanoma in the skin is related to UV exposure, but not in the eye. This is a little unusual. And yes, I did get a case. Here is a case, not mine, mine's the next one. Here's the melanoma. You see the mass? It's brown mass, black brown mass. Take a look. The retina became detached up here at the top. This is the retina that's being detached because of the mass. Retina detachment due to UV melanoma. Here's my actual specimen. I know it's black, the staining is not so good, but I do want to show you some portions. There are portions, here's the sclera, right? You can see the sclera. But notice there's black that's going out and beyond the sclera. So what does that mean? You have a mass here that's penetrating the sclera and now penetrating the organ. It's bad. It's bad. Very bad. So it's spreading. It's spreading beyond the eye. And here's the optic nerve. Right? For the retina, the one that I want to show you, very important that will always come out in your exam when you take the board because it's important. Retinoblastoma. Retinoblastoma is the most common primary intraocular malignancy in children. In children. You see this in children. I see a lot of cases in this area. Here in the Philippines too, very common. Most of the time people cannot afford surgery. So it comes in very advanced. Okay? This tumor is dangerous because it can metastasize to the brain and the rest of the body. So we have about 500 cases yearly. The early signs and symptoms of this is what is known as leukocoria. Layman's term, that's the cat's eye reflex. So usually back in the old days, when you took a picture of the people, they would take the red eyes. Nowadays it doesn't have that on the digital cameras. If you look at the person's eyes, instead of usually if you look through the pupil, you'll see a white color. And it's not a cataract, it's actually due to a tumor. So that's leukocoria. Strabismus is the eyes are focusing in different directions. Here's what it looks like. Leukocoria, the white reflex. The white reflex. Okay, here's the early case. More advanced case is left untreated. Okay. It can cause necrosis, perfusion of the eye. These are actually cases in the Philippines. These are all cases in the Philippines. This is my actual case from a 2-year-old girl. Okay. Notice the white reflex. Okay. Here's the mass when I dissected it. Here's the cornea. The lens is here. This is the retinoblastoma. Okay. It has a very unique histological finding, which I won't explain to you. It's a little bit advanced, but just know it's the most common primary, right? So that will be all for my lecture. You will have to study on your own the years because that's too long for me to cover in one. Okay? Any questions? So if there are no further questions, I will meet my batch down in the laboratory or lab, and the rest of you are